afternoon, good evening. Welcome everyone to today's Global Cafe. My name is Katrina Buzanis. I'm a Director of Policy and Advocacy at the IFA. I'm very pleased to be moderating our conversation today with Dr. Jane Carmody on the inclusion of patients and caregivers in policy development. So as the global population ages, it's important to ensure age friendliness within health systems, person-centeredness, and comprehensive health policy that supports meeting the needs of older people and healthy aging. So as the beneficiaries of health services and with growing global goals to improve health and well-being of older people, the voices of patients and caregivers must be included to support policy practice and improving care. Additionally, despite the indispensable role caregivers play, their efforts are frequently overlooked in health policy discussions. And so with us today to discuss this topic is Dr. Jane Carmody. Jane is a Senior Program Officer at the John A. Hartford Foundation. And as Senior Program Officer, Dr. Carmody works with the Foundation's leadership and staff to guide and support grant-funded initiatives in the United States. So Dr. Carmody has held significant leadership positions with healthcare systems prior to joining the foundation, including the executive director of a regional health system's home healthcare and hospice services, as hospital chief nursing officer and chief clinical leader for National Home Healthcare and Hospice Company. So Jane, such a pleasure to have you with us, and welcome to the Global Cafe.
Well, thank you so much for having me. It is so kind of weird to be here today speaking when I'm usually attending. So I appreciate the opportunity to share the information that we work on and the experiences that we have. This is a most important topic. Person, caregiver, patient, nursing home resident, the public, you and me, having a voice that matters in policy, whether it's small p, our personal or department policy, or a larger P, the policy of the government. I have been listening since April of 2020. I try to get in every Friday morning. I usually listen from home, which is why I don't have in Brooklyn, we don't have a strong enough Wi-Fi to have both video and voice at the same time. So generally I'm listening in, but I have been, I have appreciated the conversations that have come up, and I appreciate being here today. So just a little bit about me. I'll go right into that, Katrina. My husband and I moved to Brooklyn 7 years ago from what my husband usually says is people our age usually move to Florida, and we moved to Brooklyn. We have 5 children, and they were all here at that time. So we love it here, and we're so glad we came to the New York area. I am a nurse. I have worked in psychiatric care and ICUs and emergency departments, and most of my time has been in leadership and all of it in adult care. So when I was a chief nurse of a hospital and a healthcare system, I implemented programs for older people, joint camps for joint replacement, ACE units, which is acute care for elders, the niche, which is a program that is not only in the United States, but also globally, and that is Nurses Improving Care for Health System and Elders. And our president of the John A. Hartford Foundation, who is a nurse, developed and initiated that program years ago. And then, of course, other programs about hospital care that we have supported. So if you were reading any of these articles, and as a nurse leader, I am not a researcher, but I am a demand for research. So we constantly are using the research and the new knowledge that we found. And if you looked at some of this information on these programs, you would see the John A. Hartford Foundation. And I'm thinking, who are these people that care about older people? And it is the John A. Hartford Foundation. They have been in place since 1929. And when I came to New York then, I thought I'm going to just look them up and see if there is an opportunity for me there. So I tell people I actually waited on in the virtual lobby. I didn't really wait in the lobby, but I waited until a position came up and then applied, and I was hired. So I had the privilege of serving as a senior program officer, and I've been here for almost about 7 years. I'm going to go right into the foundation, Katrina, and then we can kind of talk a little bit more. So,
yeah. Oh, sorry, I was just going to say, Jen, I wonder, before we get to the foundation, because I wonder if you can tell us just a little bit about what kind of interested you in in looking at older adults a little bit? Where did that kind of passion come from? And then I would love to dive a little bit deeper into the foundation.
There you go. I would just say, I don't know that I necessarily had a moment of passion for older people. I just grew up with so many. When I had come from a large family, we had grandparents and great grandparents, and we had great uncles and aunts, and so I was surrounded by older people. So when I went to nursing school, one of the first patients I cared for was an older man who had retired and was dying from a brain tumor. And the love of the staff, the love of the family around him, I don't know, it just kind of hit me that this is what I'm supposed to do. This is where I'm supposed to be. So Katrina, even though I've had hospitals, I've had pediatrics hospitals, and I've had labor and delivery units and pediatrics units, my whole nursing career has been with adults. And so I would just say, some people have a passion that developed for some reason, but mine was just natural. It was just natural care of older adults, right?
Yeah, no, thank you. That's great. And that's a lovely way to put it. So I'm wondering, Ben, if you could share a little bit more about the John A. Hartford Foundation and kind of the core things that they're looking at to really improve the lives of older people. Because I will say, we're sharing some resources now, but that, the work is really outstanding from the organization in terms of, thinking about age friendly, thinking about really a lot of different aspects of care.
Katrina, thank you. As you know, I couldn't stop sending in links. Now, my colleague and our Vice President of Communications, Marcus Escobedo, is here on the call. And Marcus usually, for calls and talks, he usually adds in links. And I explained to him that we don't do that here, that those are added in by you. But Marcus, I just couldn't stop. And he's got more of those that we could link in. But I really wanted to have some of the links, the important things that really focus on how important the voice of patients and families are in our work and in development of local and national policy. So thank you so much for including all those on those. Look very nice. Let's see. So Katrina, we wanted to talk a little bit about the foundation at this point. As I mentioned already, their focus has been on older people since I've been known to them. But the foundation was founded in 1929, and if you're from the United States, you might recognize the A&P grocery stores, because that was the money that was used to found this group. And they've always been very interested in tech and healthcare. In the 80s, the mission turned into really focusing on older adults. And so that's what we have today. We're totally to advance the field of geriatrics. And it's really, if it's our president, Dr. Terry Fulmer, says, if it's all about older people, we're in. So that's kind of the work we are doing. We're becoming known for, as you mentioned, Katrina, age-friendly care. And I think we've talked about this. We've had our partners, Institute for Healthcare Improvement. I had suggested that they come and they presented, the information about age-friendly care. And so if you want to think about the voice of the patient and the family and the caregivers as the topic for today, when we talk about age-friendly care, that it is evolved into what we call the 4 M's. That is what matters: medication, mentation, which is delirium, depression, and dementia, as well as then mobility and function, and how important function is. And so when you think about it, the first question for us, and the question that overrides all of the care that is provided to people and in the work that we do, it's what matters. So I would say right then and there, that's where the voice of patients and families comes to being, right with that first question of what matters. So with the 4 M's, those are evidence-based. It's a framework, but those all based on evidence based geriatrics practices that they gathered over the years. And that's how we ended up with the 4 Ns. We also have a strong focus on supporting family caregivers. We support people with serious illness, as well as newly thinking about supporting, and we've had this discussion many times here about supporting social connection so that we have, less loneliness, less social isolation in the world. So let's see. I think that I want to maybe mention at this point, Katrina, or we could maybe talk about it later, but I would like to talk a little bit about the ecosystem of age friendly.
Yeah, no, go ahead. That's great.
I think we've talked a little bit about that. So there are a lot of people, I don't know, the International Federation on Aging, of course, and then a lot of the work now is being accomplished all over the world, certainly in the United States, and that is creating age-friendly ecosystems where we live and work and play. The universities, age-friendly universities, which is a global effort. We support public health to be more age-friendly. That would be a great topic to have for the World Cafe, because in the United States, now of course we all have such different ways of providing support and help, but in the United States, our public health really had not focused so much on older people. I mean, we owe our longevity to public health for the work that they do on our clean air and our water and maternal child caring. But as far as a true focus on older people, that hasn't quite been. So that was our effort years ago to start working with public health and their age-friendly, and their an age-friendly approach on older adults. And we have now taken that work and really, we work with Trust for America's Health, which would be a great topic to discuss with them. If they could come someday and talk really about the work that they're doing with age.
Yeah, thanks so much, Jane. So I want to maybe just follow up a little bit on kind of that age-friendly ecosystem that you're talking about, which is, what does that really practically look like to have kind of an age-friendly ecosystem, and how does it actually support the inclusion of patients and caregivers, which is obviously the topic of today's discussion, because I think the two are quite embedded within the principles of age-friendly is really the idea of, as you mentioned, what matters, but also really including the people that these kind of ecosystems are for, and meeting the needs of older people, but also meeting the needs of kind of the whole community or the whole ecosystem.
Right. From individuals for services that are age friendly, such as the work that we do in communities with area agencies on aging. If anyone's from the United States, these are local community-based organizations, to livable communities that the AARP has picked that up from the World Health Organization, and they are and they have delegated, the World Health Organization delegated that to the AARP to help create livable communities. So and universities, all of it starts with the people that we serve. All of it starts with what's best for them. For example, with the livable communities or age-friendly community, it starts with hearing the voice of the community, hearing the voice of older people who and what they need in their community to make it more livable, whether it's more benches, whether it's places to walk, whether it's, we were just on a call the other day about dementia-friendly America, and that started in the UK, by the way, dementia-friendly communities and dementia-friendly friends. And again, that starts with talking with people and meeting their needs. I would just say that in everything we do, and we were just talking with a researcher the other day, and she says her research, because she really researches on older people, her research starts with talking with the people that she wants to research, right? So I think that's been really ingrained more and more now. I don't think it used to be, but ingrained more and more now in the work that we do, and I think the work that's done in healthcare and universities. So we are having a convening this spring that's going to really pull together the key sectors of the age-friendly, universities, communities, health, public health, workplaces, and we're gonna find that out, Katrina. What are the common elements? What is it that what is that people need? What do we all need to do together to promote, better health and well-being for older people? And we can do that all together, even though working in our own separate sectors. I just wanted to mention something that maybe might help me. It's kind of how I think about the voice, and maybe in three different ways, three different P's, so to speak. When I was first out of school, maybe 2 or 3 years, I was working in an ICU, which is an intensive care unit for older people. It was mostly older people, surgery and medical intensive. And I had just gotten good, at it. I had just managed a code beautifully. A code means that someone had stopped breathing and heart stopped beating, and then we all worked together to get it, get that person back and doing well. And I was so proud of myself that I was able to manage all of that. And my head nurse came out and said, "Well, how's the family doing?" And I'm thinking, how's the family doing? I just managed this. I brought this lady back. She's doing well, etc. And it was her policy. It was that our policy in the unit that families were cared for as every bit as much as the patient was. So I think I like to bring that story up. The other thing that's a small policy. Then I think about the work that we did in one of the hospitals where I was a chief nurse. We developed a patient and family council. Again, that's another way that you bring voice into health systems to actually create a council, an advisory council to help you. So one of the first things we did with this wonderful patient family council that we formed was I brought in our stroke book that we had just finished. It was wonderful. It was 20 pages. It was color. And I thought they're just going to love it. And we brought it and showed it to them. And they said, "Well, that's too much. Is this for like a nurse or something?" We don't even know what it means. And so from that point on, it was our policy throughout the hospital that everything we did for patients and families, every materials, every practice, we had them walk through the emergency department to see how we could improve care. So I say that that's the policy of that hospital. And then one thing that the Johnny Hartford Foundation has done, and we have a vice president who runs our programs, and she is a family care, her education is in family caregiving, and she really has a focus and a passion for that. She worked with national governmental organizations within the United States and created for the first time a national strategy to support family caregivers, which includes a section on grandparents raising their grandchildren. So that's, to me, shows the various ways that policy can be impacted for involving and including the people that we serve.
Yeah, thanks so much, Jane. I think it's really important because I think caregivers are so often left out, as you mentioned. I think it's a really poignant example that you gave. I think it's even though caregivers they really are kind of part of this whole health system and health infrastructure and really are needed to kind of have the best level of care, but yet they're very much left out of policy and even just kind of, I think, generally under recognized for, how hard of a job that is at times, and how much it really is, an effort to be a caregiver. So I'm wondering if you can kind of share a little bit about, why it's important that caregivers are included in health policy and, how their efforts really support kind of this movement that we're making towards, age friendliness, but also kind of person-centeredness in care.
Katrina, you bring up such good points, and we learned so much from the World Cafe, especially on those kinds of comments and issues. I would just say this, and you brought up age friendly, that our foundation, our president and vice president of programs and our president of the organization will say, you can't have age-friendly care without supporting family caregivers. Family caregivers in the United States, for a variety of reasons, I'm sure it's true everywhere, but just because of the way our health system is set up, family caregivers are the backbone of what we do. So whatever program that we're talking about, family caregivers are part of it. There's a whole lot of work involved with teaching families about the 4Ms. In fact, we work with someone who cared for her husband for a number of years. And she says, as she learned about the 4Ms, it was perfect for her in terms of thinking about, now what matters to you today? What can we do today? What she managed his medications. She made sure that, he was his cognition, he was reading, he was getting, social support. And then his function, was he able to get up and walk every day? I will mention this about function as you know, there are a lot of other geriatrics practices. And so you're thinking, well, it's more than the 4Ms. Well, if you do these 4Ms, this framework, you can fit everything else in there. But I recently heard a conversation about function and how important it is. In fact, function is more important than, I think we talked about this in a couple of times ago, than the age. We also brought James Appleby from the Gerontological Society of America here to talk about the work that they're doing on reframing aging. But it's more important than the age you are, is the function that you have. And so it really should be, and is becoming more and more part of the assessment or the vital signs. It's a vital sign to figure out where someone is or can function, or what what they can manage or not. I would just say too that I was just thinking when you talked about that, and we talked about the importance of caregivers. I can't think of one program that we do that we don't involve the caregivers. I mean, there isn't one thing that we can do that caregivers. Now, one I did learn probably also from our pediatric hospital, the importance of involving parents and kids, right? I mean, that was just common to them. Nothing about us, without us. Parents and families, the parent and family council was strong, and then when you think about the hospital that I had was older people, how important it was then to also include the family caregivers. So I did learn a lot from the pediatrics and how they included family and caregivers into us. I will mention, and I don't want to go on and on, but I will mention that one program that we're really studying in the United States, and I know they have it in other places. In fact, I was talking with somebody from Brazil yesterday, and they do this just as a matter of fact, and that is provide hospital care at home. So that less and less people have to go to the hospital, especially when they're older and they have a condition that needs that does not need to be brought in, put in a bed, and cared for, and in some cases get worse. So our hospital at home program. Now, if you think about hospital at home or any care after hospitalization or any care that's provided, that involves family caregivers, because who is providing, if you're at hospital at home, who's providing the 24/7 care? And that is families. So in the beginning of that work, there wasn't a lot of thought about family caregivers. It was understood they'd be there. They kind of prided themselves in not having to have family do any of the procedures or any of the care or any of the medical health care, but soon realized that this cannot be provided without a strong family caregiver function. So for us in hospital at home, that's being studied right now, to make sure that we can support family caregivers. They have the information that they need. People that have been in our the hospital at home programs now, really a large number throughout the United States, have all loved it, but they haven't necessarily been prepared for the care that it requires.
Yeah. Yeah, thank you so much. So I want to go now just to a couple of questions and comments that have been put in the chat. So I'm wondering, just to backtrack a little bit, just because a few people were just asking if you could actually repeat the 4Ms that you mentioned and just kind of go into a little bit more detail about each of the four.
Well, that's our favorite topic, so we would be glad to. And I think we have a link, as you already put in that whole lengthy link. Interestingly enough, when our president came to the foundation, and she is a nurse, she had started, as I mentioned, nurses improving care for older adults. She knew that we weren't going to get someplace condition by condition. that we really had to look at the whole person, had to start with what matters to the person, and then, organize the care accordingly. So as a clinician, what you normally do is that you would come in, you'd find out what the problem is, what is the matter with you, look at a system review, look at the vital signs, and then say, okay, this is what we're going to diagnose and treat, and then move on. That is entirely different now under age-friendly care. Age-friendly care is a very elegant way to bring appropriate care all around what matters. So what matters to you? Well, what matters to me, and sometimes people don't really know, what are your goals and preferences? So you might have to start with, well, what do you like to do during the day? Well, I like to take care. I like to go for a walk every day. I like to take care of my grandson. I like to meet the guys, at the cafe. And therefore, knowing what's important to you and what medical conditions that you have, let's see how we can organize your care around what matters to you. These were based on, so they partnered with the Institute for Healthcare Improvement. They have come and talked with the World Cafe and talked more about this. But they pulled together all of the best geriatrics practices, and they've been around for a long time, but they weren't reaching people, right? They kind of call that we know what to do, but we don't do it, that no-do gap. And so they pulled together all of the geriatrics best practices from the geriatricians and practices and nurses and social workers, and came together and said, what are the key elements? And they boiled it down, and they eventually got to 4 M's. And the reason is that at one point they had 15, at one point they had 30, then they had 15. And as they talked with people, as they talked with clinicians, and they talked with leaders of healthcare organization, they said that's too many. So they really looked at boil it down to the 4 M's. And obviously I've mentioned, what matters, which is really the voice right there, always in the care provided. Medications, as we age, we tend to be on more medications. I think in some places that's 15, 16. But so we really have to manage and look at medications, making sure those medications are aligned with what matters. You're not necessarily so tightly controlling your high blood pressure that you can't get up and walk around, you're too dizzy, etc. So medications is probably the more common thing we think about when we think about caring for older people. And then cognitive for the mentation, and some people call that mind. But the idea is to make sure that we're assessing for cognition. How are you thinking? How are you able to manage? Then we're thinking about depression. Sometimes people think that maybe it's dementia when really it's depression. So really understanding, those are called the 3 Ds of geriatrics practices, the 3 Ds, and then delirium is something sometimes we cause through medication or through the care, surgeries, the things that we put people for. And then the last one is mobility. Now I got to tell you the quick story about Mary Tinetti. If you're in healthcare in the United States, you knew Mary Tinetti because she was all about fall prevention. So when you brought somebody into the hospital, you wanted to be so careful that they didn't fall. And so you used Mary Tinetti's work. Well, Mary Tinetti then, over the years, she worked with the foundation to look at people, older people that had multiple chronic conditions. We call that really complex care now. And she helped develop the 4 M's. And she said that if she'd have thought more about mobility, more worried about in-hospital care to get people up and moving than she did about fall prevention, she said we would have reduced a lot more falls that way. So function is important. Those together, they're really, even though they're separate, they really have to be looked at as a bundle, as we call it. If anybody's in healthcare, we put together things in a bundle, and we know we get the best outcomes when those bundles. Now, just one more comment about the 4 M's. They are a framework. So it doesn't tell you exactly what to do about mobility or what tool you have to use. But that way it leaves it up to the clinic practice, to the hospital, to the nursing home to do what works best for them. So that's the 4Ms. Now, does that cover it, or do I need to?
No, I think that's great. Thank you. Thank you so much. I think just important to kind of have that background knowledge as kind of going through the rest of our conversation, because a few people were kind of asking if you could go into a little bit more detail. And as you mentioned, we did have a global cafe just purely on the 4Ms, so people can also go and watch that back as well.
That's the beauty of the World Cafe. You can always go back.
Yeah. At this point, there's been so many that whatever topic, there's
That's
more
right.
to
It's
explore.
there.
Yeah.
So can I ask if it would be okay if Marcus could at least list what the 4Ms are in the chat?
Yeah, absolutely. Yeah. So, and
Yeah.
yes. So, and also, I believe we also just reshared kind of the link that,
Okay, thanks.
as well on what those are if people are looking for more information. But I do want to go, so I'll go back to the chat now and also come back to that kind of what matters part, which is really, again, kind of trying to include patients and caregivers and things like that. So there is another question in the chat from Shmuel, who is kind of, as you know, a regular contributor in the Global Cafes. And he's asking, what is the role of government and authorities in developing different types of patient and caregiver-friendly environments?
Thank you so much, Marcus. Well, one of the things that we do, we know when we work with leaders and geriatricians and nurses and social workers and public health and community-based organizations, we know for sustainability that once we have the government's involvement, engagement, making it a rule, we know that that practice will be sustainable. So the work that we do, I'm thinking now of the American College of Surgeons. We work with them to improve care for older people when they have surgery, or should they even have surgery. And so they, with the College of Surgeons, they always say, now, how are we going to get what we call our Centers for Medicare and Medicaid Services, the people that make the rules for what hospitals and healthcare and for providers do, always looking as the end result. Let's work on it. Let's figure it out. Let the experts and the voice of patients and families come to this conclusion that this is the best practice we should have. And then the best thing to spread it, of course, is to make it a rule, to make it a requirement. And so that's kind of how we like to look at it as sustainability. I'm looking at Marcus and also thinking about surgery. When Marcus started this work with the American College of Surgeons to improve care for older adults with surgery, one of the things they created, of course, was a stakeholder group, people involved. And the thing that the foundation brings and always brings to any of our work is where's the voice of the patient and family. Mm-hmm. So Marcus made sure that they said this was the first time that they had really created a new program with patients and families, whereas before they kind of, the surgeons kind of knew what they needed to do. So I think that kind of gives you an example. We always think that the government, and we're so lucky to work with we have great relationships. Our team, our leadership, Marcus has great relationships with the Administration of Community Living. We have great relationships with HHS, the Health and Human Services, great relationships with the AHRQ. I mean, a whole list of initials of where we try to really work closely with them. We admire them. We admire their service. We appreciate the work that they do. And we try to work closely with them so that it can become a common practice throughout the country.
Mm-hmm. Yeah, thank you so much for sharing that. And then I want to just another question from Shmuel, which relates to national programs for the inclusion of patients and caregivers. So I want to, maybe build on that and just think, ask you about national strategies and how important they are in kind of having that trickle down effect so that, you know, all of these programs that you're kind of speaking of have that voice, and that voice is prioritized.
You know, I'm going to talk about the national strategy that was just produced in 2022 and the importance of voice in that and our work with this. But before we go there, but that could be a whole topic, Katrina. We could bring someone here and talk about in the United States, the RAISE Act and the national strategy and the 350 indicators for that. But I'm going to talk first about the CARES Act. This was something in the United States that is talked a lot about in hospitals and healthcare settings, because in the CARES Act, you are to list who is the caregiver.
Mm-hmm.
It doesn't mean you involve them, but you have to list them. And most healthcare organizations have done that or did that, but now it really, the impact of making it a national thing really kind of go a long way to just finished an article on that, and I'll be glad to share that with people once that's published. But one thing I would just say about family caregivers is that clinicians just don't think about it. They're so busy with the work that they have to do. In one of my places, we were doing little videos to take to the board about what we were doing, some practices for nursing, bedside reporting, nurse leader rounding, hourly rounding, some things like that. So when we were doing videos on our best practices, I was noticing they walk in their room and they don't even speak to the family. It was like, oh my gosh, we're focused on this. And then we talked about hourly rounding, we talked about bedside reporting, but did we say and family? So, even in clinicians, you have to constantly remind them. I mentioned Mary Tinetti and her great work. She also has developed now under the practice with Marcus, actually, was to find a better way of a better way really of finding what matters for patients. So Mary Tinetti actually has the clinical practice called Patient Priorities Care. I think I sent that to you. Did I send that to you?
Yeah.
I think so. Well, let me tell you about Patient Priorities Care. That is teaching clinicians how to ask what matters and then incorporate that into the care plan.
Yeah.
One thing to ask, it's another thing to actually do it. And so in that, and that's the mention when I first was involved in her work, I saw that when you say to someone, what are your goals and preferences, they may not know. So you have to start with, with what their daily routines are. But this Patient Priorities Care also has what they call My Health Priorities. I would love it if every one of you would go in and look at My Health Priorities and see what your own health priorities are. And then you can kind of organize those. You can print them out. And then if you are going to see a healthcare provider, or not only, or for your own self, so what am I doing, to take care so that I can do what I want to do and live the way I want to live. But you can take it to your healthcare provider, and that you can talk about your goals and preferences. You can talk about what you're worried about, and you can have prepared the questions. We were just talking about that yesterday. Someone was with her mother when they went to the doctor, and she doesn't ever ask any questions, and then afterwards she thinks, oh, I wish I would have said that. So that's what it helps us to do. But I would ask all of you to do it, and then give us some feedback. We would love that. myhealthpriorities.com or .org. Is it .org, Marcus? .org.
Great. Well, so I want to go, there's a lot of questions we could go from there. I want to go to Chris that put a question in the chat. Chris, would you like to come forward and pose your question?
Sure. I just really wanted to know if you have some tips around how to recruit and support caregiver involvement when they're often so overwhelmed with the day-to-day care that they're having to provide, especially since there's been so many HHR shortages in healthcare since the pandemic.
Yeah, so you're saying not only do we have a workforce worry about attracting and retaining workforce, also the same for family caregivers.
Correct.
And so, one of the things, Chris, that I will mention and this is around dementia family caregiving, which really is one of the toughest. It has really one of the highest burdens, the highest financial burden. One of the things that we have supported over the years was research and study and practice around providing 24/7 support and support through community-based organizations. And that was with the work of David Rubin, if anyone is aware of him. He's really a dementia care expert. And his work led to what the government now is demonstrating through a demonstration project. And that is a model that will provide support for and payment for the support of 4 family caregivers in community-based organizations and respite care. So, Chris, this is what I think when I encourage families to and the work that they're doing, you've really got to divide and help. When I was I've cared for 5 older family members to their deaths, and the way I did that was because I had 5 children of my own. I mentioned the way I did that is that I would organize people. Now I had a cousin who could not tolerate the nursing homes, just couldn't. So I said, and the care that went with it. So I said, but you can do her nails. So I divided everything up. Somebody could help with laundry. I divided that up. If that is all helpful, sometimes families feel like they have to do everything themselves, but there are ways to divide it up. And so I think I would look for those. I would look for the community resources. I would look, we don't even think in the United States anyway, because we're so fragmented and we don't pay a lot for support help versus medical care. I would look to those area agencies on aging. I would look to the community supports that you have, because believe it or not, they have a lot of help there that can provide support for you. But divide and support, find the other resources that are available, and of course, take care of yourself. I think the AARP in our country does a lot to talk about that in their general public information about. There's a lot of work around that. Now, if you're an only child, and I came from a large family, when you're an only child, I know that is a lot tougher. We have people that I know when we work with, they're the only ones that are there, caring for them. Then you have to really pull in your community and your neighbors and your friends. We like to call it, friend and family caregivers. And that is one way to do it, Chris. If you have other ideas, I'm always glad to hear them.
Mm-hmm. Yeah, thanks, Jan. I wonder, is it do you see a role for caregivers in actually kind of, pushing forward that advocacy side, or do you see it more as
it's the only way,
mm-hmm.
To really get something done? We had a call with Senator Casey's office. He's a senator well known in the United States for his work in aging, for his work in supporting nursing homes, programs where people can stay at home. And we were talking about that with one of his staff. And we said, tell us about the importance. Well, I didn't say importance because I wanted to hear it from her. Tell us about when people reach out to the senator. She said that always makes a difference.
Mm-hmm.
Always makes a difference. So we have a work. There was a large study that was funded when we were seeing what was happening in nursing homes during COVID. So the National Academies here in the United States did a large study on nursing homes. And then we supported a group called Moving Forward. That'd be another great topic here. Moving Forward to put those actions into place. So there's a group within that Moving Forward that is, I think she's from Illinois, but this was the family caregiver of someone during COVID who could not see her family member in the nursing home because everybody was shut out. So they moved this forward, and in Illinois, you can no longer do that. So to me, that is where it is the strong voice. So I mentioned we did this study, we didn't do it. I mean, we supported the study with experts all over the country around nursing home care. This happened 39 years ago too. So for 39 years, our country had not studied nursing homes. In 1987, when they had produced their last report, it was caregivers and families that pushed that through to Congress to make a difference. And the rules we have in place today are because of that. So never underestimate. What did Margaret Mead said? Something about a few people that make all the difference. And in fact, it's the only way that's ever done. So it is key. And that is why we being the foundation supports whatever work we do. Where is the voice of the family? And I've heard Marcus say before many times, that's what we bring to our projects and to our work, is the voice of families and caregivers.
Yeah, thank you so much. Such kind of really powerful.
The chat, and I can see that woman is Carrie, and it is Carrie.
Yeah, yeah, absolutely. Yeah.
Yeah.
Absolutely. Okay, so I'm gonna go to another question from Wendy. Wendy, would you like to unmute and pose your question?
Yes, thank you. Thank you, Dr. Carmody. You've essentially, in a large way, answered my question. I'm from South Africa, and our nursing healthcare structures are struggling. For example, our caregivers, we can't get them, registered into a database. Their qualifications are not. They don't have a formal qualification that's recognized under our education legislation, and they are essentially the backbone of our elderly care in this country. So you're dealing with, a community of employees who are not supported financially, are not supported from a legislation perspective. They are not supported from a career development perspective. And there are, private community organizations that are busy coming up on the ground to start having the conversations about how do we actually drive this forward. And I think what I'm hearing from you is, well, we go and bang down the ward councillor's door and we find somebody who actually cares. And it's about getting private practice and business and government together to start addressing these needs, because as you've rightly pointed out, the days of caring for our elderly in hospitals and care homes, those days are unaffordable for a lot of people in this country. But how do we do this going forward? So I'm quite encouraged by especially that the community-based care, almost divide and conquer. You're saying at a level, and find someone who likes to read or do nails, or so. Yeah, thank you. And if you can add, that would be great.
Yes, and it should be done. Now, I'm relating this, Wendy. Thank you so much, and for being here always. But thank you. I'm relating this to our country in the United States, where we have lots of people coming to our country with medical degrees, social work, and they can't work. So they're driving cabs or they're working in bodegas or something. And I couldn't agree with you more. We have that now. We have to move that's the same thing here. We have to move forward so that people can work. I was just talking with a person who is an occupational therapist from Brazil. Now she can't work in the United States, and she's had 8 years experience working in the home. And occupational therapists are key to the work for older people. And so I agree. Now that I don't know. There's probably a group working on it somewhere, I'm hoping, but I'm going to look into it, Wendy, after your conversation. Yeah, I do want to mention something though. We were talking about workforce, and I think Chris, you brought it up. I don't know if this is going to help either, but I think it's going to make a difference. And that is, we're working. Our president said we're going to do something about nursing homes as well, because in our country, not that many people are interested in working with older people. When I would go to orientation with our new nurses, then I would go every week and we'd talk about, I said, we want to get you in the right place because we want you to stay. What are you interested in? They mostly wanted to work in peds and labor and delivery, right? So we're trying to create an interest in older people, because some people, when they've had that experience, they love it. So we're pairing universities, schools of nursing, which could eventually be others, and nursing homes. And it's really kind of an interesting thing to see. That would be an interesting topic here as well. Pairing nursing homes and schools of nursing, and together they're figuring out and bringing students in and creating a positive environment, creating a positive flow. So now we're seeing more students and more positive environment, and it's all around the 4 M's, which gives them a framework to work with, and the care is improving. Now, I got to tell you, many of you, some of you might know our president, Terry Fullman. She's a force. And so when this program first started, the faculty said to her, I don't think our students aren't interested in older people. So she looked at him and said, what are you telling me here? So it was really, we had to get beyond the bias even of faculty for what they needed to do. So now this is really an exciting program. I think it's in there. If you want more information, we can always bring it, or you can ask me one of the other weeks. But teaching nursing homes, because we know teaching hospitals generally have better outcomes, right? They have better quality because their environment is all education and teaching, and we're teaching the next generation. Same thing is happening for teaching nursing homes.
Yeah, that's such an interesting anecdote because, you know, those attitudes around older people are so flawed, and obviously is, you know, so yeah, as you know, people are saying in the chat, you know, the ageism is quite rampant, particularly in different healthcare settings, I think. So yeah.
Can I mention something? I know Sue Archibald is here, and Sue, I cannot tell you what a great presentation you had last week. I have just been thinking about this and all the wonderful work that you do. Did I put that up there? How did that happen? I'm not raising my hand, but anyway.
Yeah, no worries.
Yeah.
No worries. It's a quirk of Zoom. So
I don't know. Anyway, I loved your presentation. I did not know until I had talked with a physician at Weill Cornell here in the United States, in New York, that cochlear implants were for older people. And I looked it up, and Medicare covers it, et cetera, et cetera. And because I said to him, I said, so, well, with all that free over the counter now, isn't everybody using it? Well, still the stigma, of course. But Sue, I just want to call you out for what a great conversation we had last week, and great learning for me. And I know appreciate all your work and research in that area. Sorry to digress.
yeah, no.
That's sorry, can I do? That's really kind of you. And similarly, I've learned such a lot today. It's really, yeah, fascinating listening to you. There is so much to be done.
Thanks. Thank you, Sue, for jumping on again with us, which is so great. So we are coming into the end of our time. The hour always flies by. So I am just going to take 1 or 2 minutes to introduce our next week's speaker, and Jane, give you a couple of seconds to collect your thoughts for some final takeaway messages. So next week, hope you all will join us for our discussion with Professor Vivian Lau, who is the director at Sao Center on Aging at the University of Hong Kong. And we'll be talking about redefining aging, embracing wisdom as an opportunity. So I hope everyone will be on the line next week for another great Global Cafe. And Jane, I'll hand the floor back to you just for some key takeaway messages from our conversation.
Oh, that sounds fascinating. I can't wait to hear what they have to say. We're always interested in how to reduce ageism and reframe aging, etc. So I was just going to think about the word that you so carefully advise as a title, and that is inclusion. And so I was thinking about that. I was thinking about the work that our foundation does, and the work that we're seeing happen all over the country, and that is inclusion. And that is inclusion of where we live, where we work, for the care we receive, the care we seek, the education, the services we do, that it all starts with what matters. And I think that is one of the most inclusive things that we can do in our healthcare and in the full ecosystem of care. And that is to start with what matters to you and what matters to me. And that from there, we can develop policy. So we're excited, and that's why we think there's now over 3,800 some places that are calling themselves age-friendly healthcare. We have over about 700 nursing homes that call themselves age-friendly, which means they have incorporated the 4Ms in their care. And I just want to say that inclusion in all we do starts with what matters. I just will have to also say that I love the World Cafe, that I've learned so much from it, that our country has such a different system of healthcare and fragmented in so many things that doesn't work and many things that do. And I've learned so much from all of you who have different solutions in your countries. And I think that as we've noticed through these conversations, that with the World Cafe, we're making a step every week to learn something and to do something better for all of us as we age, and certainly for the folks that we care about and the folks that we want to include in every aspect of our lives and their lives. So I can't tell you what a privilege it was. I will be honest. I said, you don't need me. I just attend. But then when you think about all of the amazing work that the foundation does, it was just a privilege to share that with you, and look forward to next week's cafe.
Yeah, thank you so much. A huge thank you. And of course, we were so happy to have you and have you share, all of the work of the foundation, share so many resources and so many ideas, and every conversation, as you said, is a step forward and a piece of learning. And so we're so grateful that you were able to be with us on the line, and also are with us many of our Fridays. It's such a pleasure to have kind of our group, our community of people on the Global Cafe. So a huge thank you. And I would encourage everyone to also check out all of the resources, which will be part of kind of the post session, because Jen, you did share kind of a number of things from the foundation, but also on the 4Ms. So if people are looking for more information, I really do encourage everyone to take a look at those resources. So thank you so much to everyone, and have a great weekend, and we'll see you next Friday.